हाँ
So we are live, you can start.
Good evening, everyone. Welcome to the expert crosstalk organized by Pinnacle, a division of Lupin, on the topic Empagliflozin, multi-pronged, multifaceted, and multi-benefits. We are extremely privileged to have well-renowned experts from cardiology and endocrinology to talk on the topic. To talk from cardiology perspective, we have Dr. Ajay Sharma. Sir is consultant interventional cardiologist and professor at Department of Cardiology, Gandhi Medical College, Bhopal. Sir has authored many publications in various national as well as international journals based on the various research work. Similarly, the research work has been translated into presentations in various conferences across the globe. So I'd like to welcome Dr. Ajay Sharma, sir.
thank you.
To talk from endocrinology perspective, we have Dr. Jaideep Khare. So sir is consultant endocrinologist and associate professor, People's Medical College and Research Center, Bhopal. Sir is also involved in a lot of research work, and based on that, there are various publications in various national as well as international journals, has also made presentations on the basis of the research work in various platforms across the globe. Sir is also recipient of many awards. So Best Thesis Award in Medicine during the year 2013. Sir has got Best Paper Presentation Award in Epicon 2017 and Ideacon 2017. So RSSDI USV Award for Excellence in Diabetes Care 2019. Diabetes Awareness Initiative Award 2020, International Healthcare Award 2020. So I'd like to welcome Dr. Jaideep Khare, sir. So without much delay, I'll be handing over the session to Dr. Jaideep Khare, followed by his talk. There will be talk from cardiology perspective from by Dr. Ajay Sharma. So followed by that, if any questions from the audience will be answered by both the experts. So sir, you can take over the session, sir. Dr. Jaideep Khare.
Okay, thank you. So shall I share the screen from my side?
Yes, sir, please, sir.
So good evening all, and all are most welcome in this virtual platform, which is the new normal now. And so today's topic is regarding the empagliflozin, which is a wonder molecule, SGLT2 inhibitor, which has multiple actions, multiple mechanisms, multiple indications, and multiple benefits. So I will be talking regarding the the endocrine and the diabetes perspective, which will be followed by the cardiologist perspective, how this molecule is very good from both the perspectives. So as we have seen, we are using the SGLT2 inhibitors since very long time, since 2008 and 2000. The first one was the DAPA, then the CANA and the EMPA in 2013, and then we can clearly see several trials have came up, landmark trials which have shown that these molecules are very good, and the mechanism of actions are such, it is not basically through the pancreas, but it is through the kidneys, and has multiple actions which bring them that it is not the molecule just to control the blood sugars, but it also controls several micro and the macrovascular complications. So here there are the various novel pathways which we clearly see that it reduces the blood pressure, so thus reduces the arterial stiffness, it reduces the albuminuria from macro, several patients got converted to micro and from micro to normal, and it reduces the uric acid levels by hyperuricemic state. The slight side effect with this molecule is that it increases the bad cholesterol LDL-C, but reduces the triglyceride. So which can be very well controlled with the use of statins. It reduces the oxidative stress, it reduces the insulin secretion. So it is basically anti-inflammatory also. So here we can clearly see that the beneficial effects of the SGLT2 inhibitor may complement and improve the effects of the mainstay, which are mainly responsible for the heart failure, because it increases the natriuresis. So it may complement with the ACE and ARBs and ARNIs, MRAs, and diuretics. It improves the renal function. So again, it may be used with these molecules. It reduces the preload and afterload. So it can be used with all the molecules, and it reduces the edema because of the diuretic effect. and it has a diode effect. So, as I was saying, that the first molecule SGLT2 inhibitors were in pipeline since 1970s, with the fluorogene being the first molecule, but because it had both the SGLT1 and SGLT2 inhibition, so it has more of the side effect. So it got withdrawn. But in 2008, dapagliflozin came with the good studies, and then it came in the market. After that, the remogliflozin came in the Korean studies, and then 2015 with the Glenmark, it came over all over the world in several countries. And then canagliflozin, and then the empagliflozin, and the several trials are there with several patients. And here we can clearly see that what happens in actually in uh, type 2 diabetes. Ideally, there is a threshold that the glucose levels, if more than 180, then only it gets excreted. But in diabetic, this threshold goes up, that the blood sugars are even 300 or 400. It is the blood sugars are not sickle. The urinary glucose is not that high as it should be if the blood sugars are 300 or 400, because of up titration of the SGLT enzymes, which is present in the proximal convoluted tubule. And the SGLT2 is also present in proximal convoluted tubule, but the percentage is just 10%. And SGLT1 is mainly in the intestinal epithelium, which helps in the absorption from the intestine. And thus, SGL2 enzymes are up titrated. So, if we inhibit this SGLT2 with enzymes with the SGLT2 inhibitors, then the glucose filtration will increase. And if the glucose filtration will increase, the threshold will come down and the blood glucose levels will come down. And if the glucose is getting excreted from the body, then indirectly the calories are going away from the body. So there will be no deposition. Excess of deposition will not be there. So if we have to look for the pharmacological properties of the various SGLT2 inhibitor enzymes, then AMPA, DAPA, and CANA, which all are very good, and all can be given once a day with or without food. And the peak concentration happens even around 1 to 2 hours after the patient has taken the molecule, and the mean absorption is significantly higher with all the molecules. Its bioavailability is approximately to 60 to 75%, and there is no active metabolite of these molecules. So there are less chances that it may be producing any side effect. And if we have to look for the selectivity, then these molecules are highly selective for the SGLT2, except for the CANA, which the selectivity ratio is just 1:600. That's why I think that the CANA is having slightly more glycosuria as compared to the other SGLT2 inhibitors, which we can clearly see here, that if we have to look for the glucose excretion with the canagliflozin, it is approximately 100 grams per day, but with the other it is approximately 70 to 70 milligrams per grams per day. And if we have to look for the placebo controlled trials in which what was the mean reduction from the baseline HbA1c, then whenever it is added as a monotherapy or on metformin or pioglitazone, or with the as a third molecule after metformin and sulfonylureas, we can clearly see that there is significant amount of reduction of HbA1c seen, approximately ranging from 0.5 to 0.8%, which is very good, because if we are able to achieve the reduction of HbA1c by 0.5 to 1%, then we are able to reduce the several complications, micro and both macro. So here again, it is the same. If we have to look for the body weight, as I have told that if the glycosuria is there, indirectly we are losing the calories. So if we have to look for the weight loss, even if it is used as a monotherapy or as an add-on therapy to metformin or pioglitazone, or as a third add-on to the metformin and sulfonylureas, approximately 2 kgs weight loss is seen over the period of 3 months, which is also a good thing. In some patients, if the BMI is on the higher side, if the high BMI is there, then the reduction is more, and if the BMI is on the lower side, then the patient may complain that the patient is losing weight. So if you have to look for, then approximately 2 kgs weight loss is there from 1 month to 2 months, 3 months duration. And if we have to look for the blood pressure also, then yes, definitely, even if it is added as monotherapy or as an add-on therapy, the blood pressure reduces, maybe because of its diuretic effect, which may be explained later on in the other slides. And this is the ambulatory blood pressure monitoring studies which have shown in the type 2 diabetic and the hypertensive patient. Then yes, definitely as the duration, if we have to look for mean systolic blood pressure, if we are giving the empagliflozin and in the placebo arm, the after 12 weeks, the arms of empagliflozin, whether it is on 10 milligram or 25 milligram, it is almost similar, but the reduction is always there, approximately 2 to 5 of Hg, which is very significant. If we have to look for, if we are targeting that the diabetic patient with comorbidities, the systolic should be less than 130 and the diastolic should be less than 75. So it is very good molecule which helps in reduction of the blood pressure, both systolic and diastolic. The same is seen here. And if we have to look for the lipid profile, so there is something that the LDL levels with, yes, definitely the LDL levels have slightly increased with the empagliflozin, but it is not that significant because when our targets changes, the target ranges which change with which we have to change our treatment protocol, which will be better described by our Dr. Ajay sir. That if the LDL is more than 190, then absolutely we have to treat it. If it is more than 160 with one risk factor, we may treat it. And in diabetics, that is always a risk factor. And if the patient is elderly with two risk factors, then more than 100 LDL, we should treat it. So the target range is slightly relaxed. So this increase in LDL, yes, definitely happens, but it can be taken care with the other molecules which are available in the market. And here, these are the trials, several RCTs which have clearly shown that if we have to look for the HbA1c reduction, it is the same thing which I have described in the tabular form, or we have to look for the fasting plasma glucose or the mean body weight or the systolic blood pressure. Significant reduction is there as compared to the placebo. And if we have to look for the safety profile, then definitely there a patient with any adverse event, if we have to look for, then the patient in the placebo arm also had some amount of adverse event. And if we have to look for in the empagliflozin arm, definitely they had. So, but it was not that significantly on the higher side that we have to think that it is a bad molecule. And requiring the discontinuation, it is almost similar in placebo and in the empagliflozin arm. And if you have to look for death, then yes, death is slightly, if we have to look for all cause mortalities, then death in empagliflozin arm is definitely lower than the placebo arm. So yes, it improves mortality, which we have discussed several times, and everyone must have heard about the three MACE points and all those things, that 34% reduction is there. And if we have to look for the other side effects, like the urinary tract infection, which is very much talked about, and the severe kinds like pyelonephritis, urosepsis, genital infection. I will just say that diabetic patient itself are at more risk of UTI if not diabetes are not very well controlled. So if we have to look for this comparison arm, definitely the numerically in empagliflozin arm, the ratio of patient is slightly on the higher side, but it is not significantly higher because we should look for the other things also. So severe kinds of UTIs are significantly lower in cases of empagliflozin as compared to the placebo arm, because uncontrolled diabetes leads to severe forms of UTIs. And if we have to look for genital infections, yes, if we will explain the patient that they have to take the proper genital hygiene, then the risk of this, the numbers which we are seeing here will be significantly lower. And if the blood sugars are very well controlled, then genital infection rates will be significantly on the lower side. And if we have to look for the volume depletion, we should use this with the caution. It should be avoided in the patient, those who are very elderly and those who are at risk of volume depletion. We should avoid this molecule. Why? We should not think that this molecule has to be given to every patient. It is a good molecule for some and good molecule for others. So if we have to look for the empagliflozin and cardiovascular outcomes, EMPA-REG outcomes, and this will be discussed later also. So I will not discuss about that. I will just discuss about the renal outcomes. So in the renal outcomes, we will say that incident of worsening of nephropathy was significantly higher in placebo arm, and the progression of macroalbuminuria was significantly higher in placebo arm. And if we have to look for the composite renal outcome, then it was higher in the placebo arm as compared to the empagliflozin. So yes, in patient with type 2 diabetes, there is high CV risk. Empagliflozin gives additional benefits in reduction of it, and yes, and definitely there is a reduction in the renal adverse renal outcomes also. And these are all 3-point MACE which we have discussed. We know very well that yes, the 3-point MACE, cardiovascular death, non-fatal MI, and non-fatal stroke are better in the empagliflozin arm. And if we have to start with the empagliflozin, then now the guidelines also are there that we can start with the empagliflozin directly, SGLT2 inhibitors directly, if the patient is having high risk of high cardiovascular risk, or the patient is having risk of renal diseases. So I will just escape through all those trials, and these are the trials which started with the CV after the 2008, when the saxagliptin has shown that it increased the risk of hospitalization. FDA has given the strict instruction that any new molecule which is coming in the market has to go through the uh, cardiovascular safety CVOT trials. So these are the trials which are seen here and have shown several superiority and non-inferiority. So if we have to look for the guidelines, then as we see in the guidelines that lifestyle modification and the metformin. After lifestyle modification, metformin is the first line until unless contraindicated. So here in the newer guidelines in 2020 with the ADA, which has clearly shown that if the patient is even drug naive, but if the ASCVD score is on the higher side, or if the patient is at high risk of cardiovascular diseases or renal diseases, start with the SGLT2 inhibitors or GLP-1 receptor agonists as compared to the metformin. So I will just end here, and I will request Dr. Ajay sir to start his presentation. Thank you.
Thank you very much for your insights, sir. Now I request Dr. Ajay sir for his perspective in cardiology.
Yeah, thank you. Dr. Jaideep has already briefed nicely about its effect on as oral anti-diabetic drug. Now, I will be talking about its effect on heart failure and other impacts. Next slide, please. So, as we have known that, which has already been briefed by Dr. Jaideep about EMPA-REG trial, and apart from EMPA-REG, there were other trials which were done particularly in diabetic patients only. That was CANVAS, DECLARE, and VERTIS. And all these trials have clearly shown that there is significant decrease in hospitalization for heart failure, decrease in cardiovascular death, as well as positive kidney outcome with EMPA. Next slide, please. EMPA-REG trial, which has clearly demonstrated cardiovascular outcomes and deaths from any cause, and it has shown that primary outcome of 3-point MACE, cardiovascular death, or death from any other cause, and hospitalization from heart failure has decreased with EMPA compared to placebo. Next slide, please. In diabetic trials, particularly in Look Ahead, Live,
Ajay sir,
Renal,
sorry to interrupt.
right?
Your camera is not visible, sir. It's back
Okay.
camera started.
My camera is on. I don't know.
It's looking it's your back camera, sir. Can you please turn on to
Just a
the front? Yeah. Now it's perfect, sir.
So,
You can continue. Thank you.
yeah, sorry. So, in different diabetic trials, it was clearly shown that heart failure is a more common outcome than myocardial infarction, stroke, and death. And particularly, incidence of heart failure increases with the duration of diabetes. Next slide, please. In trials like EMPA-REG, which was done in SGLT2 inhibitors, and there are different trials done for GLP-1 receptor agonist as well, and they have shown positive heart failure outcomes of glucose-lowering agents, particularly GLP-1A and SGLT2 inhibitors in diabetic patients. Next slide, please. This is again the same slide, which is of EMPA-REG, which has shown that heart failure outcomes has improved significantly in patients with EMPA compared to placebo. Next slide. Pathophysiology again, which has already been briefed by Dr. Jaideep, is natriuresis, improved kidney function and cardiorenal physiology, reduced preload, afterload, and reduction in LV wall stress. This is very important. This reduced preload, afterload, and reduction in LV wall stress lead to decreased heart failure incidence with EMPA. There is also decrease in interstitial edema. Next slide. So as we know that there are therapies which only prevent heart failure. These therapies are statins and educate BP control. But now SGLT2 inhibitors have also come into vogue, and they are the drugs which are to be given in heart failure patients, and they prevent progression of heart failures. There are therapies that treat established heart failures, that are ARNI agents like sacubitril, valsartan. Then definitely devices like CRT, ICD, and MRA agents, they also treat established heart failure. And we know ACE inhibitor and ARBs, they are the well-known drugs, and they both treat and prevent heart failures along with beta blockers and exercise. Next slide. Guidelines, this has again been briefed by Dr. Jaideep that, yeah, we do consider lifestyle modification and metformin as first-line therapy. But if patient is having atherosclerotic cardiovascular disease, or there is high probability of cardiovascular disease risk factors, then it's always better to start with SGLT2 inhibitors, or if patient is already on metformin, that it has to be added on. Next slide. Most important trial which has come just now is Emperor trial, which has remarkably changed our perspective about this wonderful molecule. Next slide. So the design and the rationale of this Emperor trial was like patients were taken with chronic heart failure with reduced or preserved ejection fraction. And patients were both diabetic and non-diabetic. 50% of the patients were non-diabetic as well, those who were given this empagliflozin. So in Emperor reduced trial, patients with reduced ejection fraction, which was defined as ejection fraction of 40% or less at echo was taken, and there should be evidence of elevated anti-pro-BNP levels, and those patients should also be on appropriate dose of medical therapy for heart failure, which are ACE inhibitor, ARBs, beta blockers, MRA, ARNI agents, and appropriate device therapy, which are consistent with prevailing guidelines. In Emperor Preserve trial, patients with preserved ejection fraction, which was defined as ejection fraction of 40% or more. And along with that, presence of one or more of the following was also needed. That is structural heart disease, that left atrial enlargement, or LV hypertrophy in echo, and evidence of hospitalization for heart failure 12 months prior to screening. And there should also be elevated anti-pro-BNP level. Next slide, please. So the like these trials, Emperor reduced and Emperor, has been taken to determine the efficacy and safety of empagliflozin in patients with heart failure. And the effects of EMPA on symptoms, exercise capacity, patient-reported outcomes are also being investigated in a parallel imperial trial. Together, these trials were expected to deliver conclusive insights regarding the value of empagliflozin treatment for patients with heart failure. Next slide, please. Mechanism, I would go into a short, already brief. They reduce preload, they increase natriuresis, they decrease interstitial edema. But at molecular level, SGLT2 inhibitors increase fasting level of ketone bodies, which is hypothesized to enhance utilization of this efficient metabolic fuel in failing heart. Along with this, it was postulated that SGLT2 inhibitors may slow the course of cardiomyocyte injury and loss by inhibiting sodium hydrogen exchanger. Second, it was seen that EMPA has been shown to inhibit the activation of calcium dependent kinase 2, which contributes to the activation of NHE1 and thereby decreasing cardiomyocyte injury. The action of EMPA to prevent calcium overload may explain why the drug prevents time-dependent decline in systolic cardiac function in patients with heart failure. Next slide. So Emperor reduced trial, I'll go into the detail later on, but it has clearly showed that EMPA is superior to placebo in improving heart failure outcomes among patients with symptomatic stable heart failure with ejection fraction of 40% or less, and which are already on excellent baseline guideline directed medical therapy irrespective of diabetes status. Next slide. The goal was again to assess the safety and efficacy of this drug in patients with symptomatic heart failure with reduced ejection fraction. Next slide. So the study design was patients were randomized to a 1:1 fashion to either EMPA 10 mg or placebo. Total patients who were screened were 7,000 approximately, of which enrolled were 3,700. Duration of follow-up was 16 months. Mean patient age was 16 years and female patients were about 24%. Next slide. Inclusion criteria, important, age more than 18 years, patients of chronic heart failure with NYHA functional class of 2, 3 or 4, ejection fraction of 40% or less, history of heart failure hospitalization within 12 months, and elevated NT-proBNP level. Next slide. Patients, those who were excluded were of ACS, stroke or TIA within 90 days, those patients who are listed for heart transplant and who are currently on LV assist device, and certain patients like cardiomyopathy based on infiltrative diseases, muscular dystrophy, hypertrophic cardiomyopathy, cardiomyopathy due to pericardial restriction, peripartum cardiomyopathy, and cardiomyopathy caused by chemotherapy were also excluded. Patients with severe valvular heart disease and acute decompensated heart failure were excluded as well. And if at all patients have been implanted ICD or CRT within 3 months, they were excluded. Next slide. Silent features which was seen in these trials were whites were 70%, Asians 18%. Maximum patients were in NYHA functional class 2, that is 75% patients were in NYHA class 2. Mean ejection fraction taken off was 27%. Only 50% patients were type 2 diabetics. 50% were without any evidence of diabetes. Then almost all of these patients were on optical medications, including ACE inhibitors, ARBs, then ARNIs, MRA agonist, and beta blockers. Next slide. So the primary outcome, which was a composite of cardiovascular death or heart failure hospitalization for EMPA versus placebo, was 19.4 versus 24, which was statistically significant. Cardiovascular death was 10% versus 10.8, which was also again significant. And heart failure hospitalization was 13.2% in EMPA group compared to 18.3% in placebo group. Next slide, please. So there was 25% decrease in composite of cardiovascular death or heart failure hospitalization, which was primary endpoint. And first secondary endpoint, which was first and recurrent heart failure hospitalization, was decreased by 30%. And second secondary endpoint, which was slope of decline in GFR over time, was decreased remarkably by 50%. Next slide. Again, this is a graph which is showing that there is significant improvement in cardiovascular death or hospitalization for heart failure with EMPLA. And also composite renal endpoint was significantly, there was positive renal outcome with EMPA compared to placebo. Next slide. So if we come into the real thing, the Emperor reduced trial with EMPA will have a major impact in the times to come on the management of patients with chronic heart failure and reduced ejection fraction, whether or not they have diabetes. There is now compelling evidence that SLG2 inhibitor should now be added to currently recommended treatment for this chronic heart failure patients. Next slide. Serious adverse events were more or less same in placebo and EMPA group, except for UTI and genital tract infections, which are definitely due to increased glucose excretion through urine. Next slide. So the conclusion again stressed that among patients receiving the recommended guided therapy for heart failure, those in EMPA group had a lower risk of cardiovascular death or hospitalization for heart failure than those in placebo group, regardless of the presence or absence of diabetes. Next slide. Secondary outcomes were also significant, like total hospitalization was decreased, composite renal outcome of chronic hemodialysis, renal transplant, profound sustained reduction in GFR was less with EMPA group, all-cause mortality was less, new onset type 2 diabetes among patients with pre-diabetes was less, change in hemoglobin A1C level was definitely there with EMPA compared to placebo. And confirmed hypoglycemic event was more or less same in EMPA as well as placebo group. Next slide. So the mechanism is reduced cardiac preload, shift to ketone metabolism, adaptive cellular reprogramming, improved endothelial function, inhibition of sodium hydrogen exchange leading to decrease in the cardiomyocyte injury and reduction in cardiac fibrosis in long term. Next slide. The results of this trial indicate that empagliflozin is superior to placebo in improving heart failure outcome among patients with stable heart failure with reduced ejection fraction, those who are on excellent guideline-directed medical therapy, irrespective of diabetic status. Benefit is primarily driven by reduction in heart failure hospitalization. So there is definitely an economic point of view as well. There was also a benefit in renal outcomes in long term. So this is a very important trial, and it mirrors similar findings from the DAPA, which is for the dapagliflozin, DAPA-HF trial for dapagliflozin. Even patients with severe LV dysfunction appear to benefit. Next slide. Even though SGLT2 inhibitors were introduced primarily as type 2 diabetic management drugs, the result of EMPA-REG outcome trial, which was done in diabetic patients, and other indicated a clinical benefit in heart failure management. Therefore, this EMPEROR trial was undertaken, and this trial, which enrolled a dedicated heart failure population and has conclusively showed a benefit in these patient population, irrespective of diabetic status. These drugs will definitely have a prominent role in future heart failure management guidelines. Next slide. Next one. So if you look into this from diabetic perspective, these SGLT2 inhibitors exhibit lower incidence of side effects, namely hypoglycemia, which is experienced with use of some of the currently available anti-diabetic drugs. Also, these SGLT2 inhibitors has shown to cause some amount of weight loss, which is beneficial for patients with diabetes. And these drugs strengthen current armamentarium of oral drugs used to treat type 2 diabetes and has emerged as a cardiorenal game changer. So if we, the take home message would be that in patients with chronic heart failure and reduced ejection fraction, EMPEROR trial particularly has shown that all three endpoints pre-specified have decreased significantly with p-value of less than 0.001. 25% decrease in the risk of composite of cardiovascular death and heart failure hospitalization observed in EMPEROR reduced trial was identical to that seen in DAPA heart failure. So EMPA also reduced the total number of hospitalization for heart failure and slowed the rate of progression of renal disease. Hence, SGLT2P inhibitors, particularly EMPA and DAPA, will emerge as new standard of care for patients with heart failure and decrease ejection fraction in times to come. Thank you.
Thank you very much, sir, for your insights. Now, we have few questions from the audience. Sir, with your permission, Dr. Jaideep, sir, also. So, can we take those questions, sir?
Yeah, sure.
Sure. The first question is, when to add SGLT2 inhibitors in the treatment for heart failure patients?
See, like after this EMPEROR trial, it's clear that if a patient is, even if a non-diabetic patient, particularly for diabetic patient, it's a good drug. Even if non-diabetic patient and if ejection fraction is less than 40%, and definitely in India, we will not be able to do anti-pro BNP level in each and every patient, but still, if there is history of hospitalization for heart failure, as well as there is increased cardiac risk factors, which you can assess by other risk factors, evidence of atherosclerotic disease, then definitely patients should be put on this drug SGLT2 inhibitors. And there would be more trials in the times to come, which will compare DAPA as well as with EMPA head to head. And then we will know which drug is better, whether DAPA or EMPA. But definitely, as of now, it seems that these drugs should be added to the current armamentarium of heart failure drugs, and they will definitely have a role in mortality as well as decrease in heart failure hospitalization.
Okay. So next question is in fact related to the answer which you recently, you just gave just now, sir. So in heart failure patients, which should be the first choice? It has to be EMPA or it has to be DAPA? So there is the
Uh,
next question. Yeah.
if you go into this, like even DAPA heart failure trial has shown substantial benefit. And I was going into the like literature. So AMPA, 2 or 3 points are favorable for AMPA. First one is, I don't know, but one trial documented that AMPA is more effective in reducing HbA1c level compared to DAPA and improving other cardiometabolic parameters. This was like published in PubMed 2019, particularly if it was used as fourth drug in type 2 diabetic patients who were inadequately controlled with metformin, glimepiride, or DPP-4 inhibitors. So if you see HbA1c reduction was more. Second, AMPA has greater selectivity for SGLT2 receptors. Third, AMPA uh, effect on renal outcomes was quite remarkable compared to DAPA. But still, there is no head-to-head trial between DAPA vis-a-vis AMPA. And in the times to come, we will see which drug is better. And but as of now, I think both drugs are on same ground, same footing. And time is going to tell us whether we should go with AMPA or DAPA.
Okay, sir. Sir, anything you would like to add, sir? Dr. Jaideep, sir?
No, nothing. Sir is, sir has given the answer that it will take time will tell us that
Okay.
which will be the better molecule in the future.
Okay, okay. So next question is, sir, when to prefer SGLT2 inhibitors and GLP-1 analogs in diabetic patients? So no, they both have cardiovascular benefits. So how to decide, which patient is eligible for which one?
See, trial-wise, like both have documented that SGL2P inhibitors as well as SGLT inhibitor as well as GPLA receptor agonist, both have got positive outcome effects. But I don't have like, I don't know, Dr. Jaideep would be better to just like,
Sir,
as
I
far
will
as
say one
diabetic
thing
status is
in
concerned,
yes.
whether like you are using this GPLA receptor agonist or not, I don't know. But
Sir, I am using the biggest drawback with the GLP-1 receptor agonist in India is that these are injectables, and patients are very much afraid of injections.
Yes, sir.
yeah,
So one drawback with this, and once the semaglutide will come in the market, then we will see. And the GLP-1 receptor agonist, the cost therapy is very high as compared to the SGLT2 inhibitors. Both are equally good. GLP-1 have been used in the type 1 diabetic patients also, and these were very successfully good for the type 1 diabetic. But these two parameters come out. If we have to look for the efficacy wise, SGLT2 and GLP-1 both are equally good.
Okay, sir. Okay, sir. So next question is, sir, what should be the cutoff EGFR levels when SGLT2 inhibitors are used?
sorry.
The cutoff is coming down with the studies coming up. With the
Okay.
Canagliflozin, it came up to the 30, and now with the DAPA CKD, it had came up to 20. So with further studies, the EGFR cutoff may further come down, and we may start using it in the end-stage renal diseases also because of its other benefit, not for reducing the HbA1c.
Okay. Okay. Ajay, sir, would like to add anything to this? So the question is,
So,
what is the cutoff EGFR levels for starting SGLT2 inhibitors in a patient?
yes, Dr. Jaideep has told, definitely right now there is EGFR level is being seen, but in the times to come, it will be used in ESRD as well as end stage renal disease as well. As
Okay.
of now, they are like excluded, but in the times to come, they will also be included, I think.
Okay, sir. One more last question, sir. So, in the diabetic female patients with frequent urinary tract infections, so can SGLT2 inhibitors be used?
I will say avoid it in the females, those who have recurrent UTIs, because these are the potential patients, those who develop severe kind of UTIs, and the pyelonephritis is also seen. If the patient, lady especially, is willing to have proper hygiene and had not had the UTI in last 1 year, then only we can give that trial. Otherwise, avoid, because it is not necessary to give SGLT2 inhibitors to every patient. We should
Okay,
think
sir.
that it is a good molecule, but it should not be given to all. We have to use it wisely.
Okay, better to
So,
avoid it, but taking the case, I mean, knowing the history of the case is also important before
yes.
starting the drug. Yes. Okay, so I mean, there are no more questions, sir. So I think we have come to the end of the session. So the audience would have thoroughly enjoyed the session and enlightened by the exceptional talks. from both cardiology as well as endocrinology. From Lupin, we are extremely thankful for accepting our invitation and sparing time for this expert talk, sir. So have a good night and a great weekend, sir, from Lupin.
Thank
From
you.
us.
Good night, sir.
Good night.
Thank you, sir. Good night, sir. Good night.
Good night.
Yeah.